My name's Orly Klein. I'm a stem cell transplant here at Stanford, and I am very honored to introduce Raúl Montiel-Esparza. He was our first clinical fellow in stem cell transplant, and he was a very excellent fellow, and he is now an attending physician at Cure for the Kids Foundation in Las Vegas, and he is a clinical assistant professor at University of Nevada, Las Vegas. And he's going to be presenting his research to us of dissecting biomarkers of acute GvHD in alpha beta T cell CD19 B cell depleted haploidentical stem cell transplant. So Raúl, take it away.
Thank you, Orly, for that presentation. I met Orly when I was a postdoc learning about PT-Sci at Hopkins, and she was a fellow herself. She helped me make my residency application and put it together. So it's nice to see the other side of the coin when I was lucky enough to join Alice's lab here at Stanford. Today I'm going to talk a little bit about the project that I did while I was a fellow here, and talk about two pilot studies that we conducted to understand the predictability of biomarkers in this transplant setting for pediatric recipients. As you all know, an alpha beta T cell depleted graft provides a large amount of gamma delta T cells and NK cells that provide graft versus leukemia effect for those that have malignant conditions. And however, up to a little more than 15% of recipients of alpha beta T cell depleted grafts unfortunately developed graft versus host disease. And when there is steroid refractory disease, mortality can be as high as 80%. Yesterday was briefly discussed that clearly the timing, the clinical presentation, and the pathogenesis of GvHD is different between T cell replete settings and alpha beta haplo depleted settings. And there are still no clear guidelines or tools to help us take care of patients that get an alpha haplo. Over a decade, the MAGIC Consortium, or the Mount Sinai Acute GvHD International Consortium, has sequentially reported and validated the predictability of these 7 biomarkers alone or combined when it comes to GvHD as early as post-transplant day 7. And this originated from the knowledge of ST2 and REC3 alpha that are anti-inflammatory proteins that are located in the Paneth cells of the GI lining that get released when there is damage from the conditioning regimen to the GI tract. And this led them to formulate an algorithm that as early as post-transplant day 7, and it has been clinically validated that they're able to estimate the probability of acute GvHD, the severity, whether there's going to be GI involvement, and the 6-month non-relapse mortality. It's important to note that this was done in T cell replete settings, and using their pre-symptomatic algorithm and using their COTA values, they were able to divide those patients that were high risk of developing GvHD versus those that were low risk. And then using their symptomatic and post-treatment algorithms, they divided patients in 3 different groups, low risk, medium risk, and high risk, to see whether response to steroids was going to occur or not, which led us to develop our aims for this project. First, wanting to identify circulating immune activation biomarkers as predictable indicators of GvHD as early as post-transplant day 7. And we wanted to use this clinically validated algorithms and see whether it applied to the alpha beta haplodepleted setting. And then later in the talk, I will discuss a little bit about what we did to understand whether there was a role of graft-derived T cells and donor-derived T cells, and understanding their gene expression profile and their role in the development of GvHD. First, with the MAGIC algorithm, what we tried to do, we did this retrospective pilot study in which we studied 27 patients, 27 recipients of median age of 11 years, both with malignant and non-malignant conditions. And as you can see, 15 of these developed GvHD. The median day of onset was day 30. And according to what is known from the pathogenesis of GvHD in alpha beta haplos, the organ that was most commonly involved was the skin. We obtained cryopreserved serum from both of these groups, whether they developed GvHD or not, and analyzed different time points, which include day 0, day 7, day 14, 28, 100, and GvHD onset. This was prior to them receiving GvHD-directed therapy. And we sent it to the reference laboratory of the MAGIC consortium for analysis of the MAGIC algorithm probability score, and also individual biomarkers that have been clinically validated. And this was to see whether we could predict at day 7 again whether our patients were going to be at risk of severe GvHD, whether they were gonna have GI involvement, and the ranges for individual biomarkers were obtained from the Central Laboratories website. To start with, we noticed that the MAGIC algorithm between the groups of our patients did not show any statistical significance at any of the time points. We did observe a higher trend at day 28. However, by day 28, almost half of our patient cohort had already developed GvHD, so it made it challenging for clinical decision making. And then looking at the individual biomarkers, which include REC3 alpha, SC2, LFN, IL-8, HGF, soluble TNFR1, and soluble IL-2 receptor A, there were no statistical significant differences at any of the time points. It was interesting, and I'll put a pin on it for the next part of the discussion. IL-8 at day 7 showed an interesting trend that we observed as well in the next studies that we did. Looking at whether there was association of severity of GvHD from what we knew what clinically happened in our patients, using the cutoff values of the pre-symptomatic algorithm, at day 7, we didn't see a correlation of for those patients that were labeled according to the algorithm of being at high risk, since we saw that those patients had grade 1 and grade 2 GvHD, and low risk patients according to the algorithm ended up having grade 4 GvHD. And that was the same case at day 14, 28, 100, and onset, using the other algorithms that subcategorized patients into low risk, medium risk, and high risk. 24-month on non-relapse mortality rates using Kaplan-Meier curves also showed no correlation using the MAGIC algorithm in these recipients since the high-risk patients seem to have done, according to the algorithm, better than the low-risk patients, which was not the case. We also wanted to see whether there was a correlation with GI involvement, severity, and conditioning regimens. And throughout the time points, we did not observe correlation between the MAP score and whether there was GI involvement, as you can see at any of the time points. There was also no statistical significance for those 6 patients that had some GI GvHD on whether the MAP score was going to be able to predict GvHD, and also whether there was a non-myeloablative or myeloablative conditioning regimen had to do anything with it. So to conclude this part of the talk, we realized that the MAGIC algorithm did not seem to predict GvHD, non-relapse mortality, severity of GvHD, or GI involvement in the alpha-beta haplorecipients. And we hypothesize that this is very likely due to the fact that with the large doses of gamma delta T cells that are provided with the graft, these home to the GI, stimulating regeneration of the epithelium through keratinocyte growth factor, and also repairing the tissues that were damaged. So taken together, we concluded that these biomarkers appear to be more predictive in T cell replete settings, where, as you all know, alpha beta T cells are the alloreactive cells that are responsible for the pathogenesis. So with that being said, we wanted to see whether graft-derived and donor-derived T cells, if tracking them throughout transplantation in an alpha-beta haplodepleted setting, whether in doing RNA sequencing, whether we could understand how GvHD happens in this setting. And we wanted to dissect the genomic profile of donor residual T cells in graft-derived T cells using single-cell gene expression profiling. And we hypothesized that these T cells that come from the donor and the graft are the alloreactive T cells that trigger and start GvHD in the recipients. And we used Rhapsody, the Rhapsody technology, which provides simultaneous immunophenotypic profiling as well as mRNA sequencing. And we wanted to track the TCR of these residual cells through transplantation. And this with hopefully having the global outcome of whether there's a role for further graft manipulation, whether there's integration of immunotherapies like we discussed tocilizumab or anakinra, and the potential role of whether this could play into the donor selection process. For this part, this pilot study, and please bear with me, this is a slide that is a little complicated, but I try to color code it. We did this retrospective exploratory study to assess whether a single-cell RNA sequencing had a role in future graft manipulation strategies. And we obtained cryopreserved PBMCs from 3 paired donor, graft, and recipient samples that were all related to each other. And the T cells were magnetically isolated, then labeled with oligonucleotide and with antibody-specific barcodes, and then processed by the BD Rhapsody technology, so we could, as I mentioned, get simultaneous information on their immunophenotypic profile, and also do single-cell RNA sequencing. To summarize how the samples were organized, I divided them in 3 paired groups of their donors in light blue, their respective, and this is before mobilization, before depletion, obviously, their grafts after those procedures, and 2 post-transplant time points in the recipients. Group A and Group B, their recipients had GvHD, and Group C recipient did not have GvHD, so we could have a control. For the immunophenotypic part, it's organized in Group A, B, and C, and then everyone overlapped together. But multidimensional immunophenotypic profile showed a very interesting dynamic intersectionality in my mind. In light blue, the donors located to the central part of the Tisney, and then after mobilization and depletion, their grafts were pretty different, differently located, which led me to believe that something quite interesting is happening to these same T cells after they are mobilized and after they're depleted. And then for the post-transplant time points in the recipient, these T cells located here in orange in interesting uh, positions for group A and group B, which were the GvHD groups. The orange cells located in the upper part of the Tisney, but for group C, it was sort of in the middle in the lower section. And the next post-transplant time point was also a little different between the patients that had GvHD and the one that did not. Looking at antibody immunophenotypic profiling, we noticed that most of the cells that were located in the upper part of the Tisney were likely CD8 T cells, and sort of in the middle and lower part more CD4 T cells that were not as CD45 positive as in this section. So we concluded with this part that the heterogeneity of T cells differs across time points in alpha beta haplo, probably. Another thing that we wanted to see is whether the gene expression profile differs throughout transplantation of these T cells in the alpha beta haplodepleted setting. And the way that this chart is organized is it's aligned with every row. And markers of T cell activation were organized in this way, showing that interestingly, HLA-DR at the time of onset for the patients that had GvHD seemed to be more expressed than in the patients in the recipient that did not have GvHD. The others did not, as we predicted, well, as we expected, they were not as highly expressed. But then I looked at other markers, including immune checkpoints, and it was interesting to see that CTLA4 correlated with being high at the onset of GvHD, which in my mind told me that the role of abatacept for patients that have GvHD at this point, and as you can see, the patient that did not have GvHD does not have as high CTLA4. Other markers that we looked at are markers of inflammation, and interestingly, IL-8, which is what was high in our MAGIC algorithm studies, was higher from the get-go in the donors for the recipients that had GvHD, but not for group C. And then we previously talked a little bit about IL-1B. In the graphs of the patients that had GvHD, it was a little bit higher than the patient that did not have GvHD. But I know that larger studies have been done here that we haven't found a big relationship with that. IL-6, I was surprised to not see as much elevation, even though it's a highly expressed cytokine during an inflammatory response. And the next part of this pilot study, we wanted to track the TCRs throughout transplantation. And using group A, we noticed that we were able to find the same cell that was present in the donor according to its CDR3 region, and then going into the graft here in the purple triangle, and then at the onset of GvHD. The nucleotide sequence of this specific cell led us to know that it was a CD4 naive T cell. This led me to understand that one can track specific T cells throughout transplantation in this setting and probably play a role into selecting or better manipulating a graft. So with this part of with this experiment, as I mentioned, it led me to conclude that mobilization with what GCSF and plerixafor may play a role into the immunophenotypic landscape of donor T cells and may also even alter the gene expression of these cells. And this could lead to better or more novel graft manipulation and even donor selection strategies, or even finding therapeutic targets such as anakinra, tocilizumab, and I don't know about IL-8 yet, but it could be. I learned that tracking of the TCR repertoire is possible in alpha beta haplo transplantation, and I didn't show this yet because it's still in the works, but we did see substantial colon expansion and onset of GvHD. So to conclude, what we learned from our experiments is that clinically validated biomarker algorithms do not seem to predict GvHD in our setting, since it's not a T cell replete setting. And as we discussed, that the heterogeneity of T cells and their gene expression profile probably differs throughout transplantation. So with that, I'd like to finish the talk. Even though I don't go here anymore, I'm still in very close contact with everyone. I was very lucky to be part of the clinical fellowship program, and I'm lucky to call Alicia a friend, and thank you for having me. Thank you. I'll take any questions.
Nice work, Raúl. Do you think that there would be anything of yield to look at different time samples after GvHD? For example, at the very first symptom onset, 24 hours later. I just don't know. I'm sure people who do a lot of biomarker things probably know this, but when we look at some other inflammatory markers, they follow like a pattern. And I'm just wondering, if you got samples at different times, would you think that maybe some of these expressions may change over time?
Yeah, I absolutely think so. And I think that was the main limitation of this project, just because we were doing pilot studies. I'm curious to see what would happen to the donor T cells after they've been mobilized but have not been depleted yet. We didn't get that crucial time point to differentiate what the isolated effect of just immobilization is and the depletion is. But yeah, I think that was a big one that we want to do next. Great. Thank you so much.